Hello, everyone. We're going to be talking today about palliative care for chronic kidney disease, which is basically a topic that really important for both the palliative physicians and pain fellows as well. We'll be going through these objectives today. A chronic kidney disease, by definition, is defined as abnormalities of kidney structure or function present for a minimum of 3 months with implications for health. It's classified on the base of the cause, glomerular filtration rate, and the albuminuria category or albumin creatinine ratio. Stage 5 is what we all know as end stage kidney disease. The main cause for end stage kidney disease is diabetes. Following the diabetes is high blood pressure. And then we have different types of diseases such as glomerulonephritis, cystic or hereditary congenital diseases, urological diseases, and other causes. This is the classification of chronic kidney disease. It's either classified by GFR or by the albumin creatinine ratio, or in fact, even better, both of them together. Once you reach stage 4, you're in the irreversible stage. Okay, so actually, stage 3B is very important because it kind of delineates between being reversible and being irreversible, and the need of renal replacement therapy. Um, Basic signs and symptoms in end-stage kidney disease include nausea, vomiting, loss of appetite, changes in urine output, muscle twitches and cramps, hiccups, peripheral edema, itching, chest pain, shortness of breath, high blood pressure, mild anemia, and GFR decreases gradually from 90 to 30 ml per minute. Okay, so the diagnosis is based on the kidney function test, glomerular filtration rate, uh, serum electrolytes, urine dipstick for protein, abdominal ultrasound, and urine routine and microscopy. Complications of chronic kidney disease include cerebrovascular disease, hypertension, protein energy malnutrition, peripheral neuropathy, anemia, end-stage kidney disease, and metabolic bone disease. So with chronic kidney disease, it actually typically affects elderly. The average age of those starting chronic dialysis in most developed countries is about 65 years old. Kidney diseases are basically or organ failure fall in this category here in this picture, um, like heart failure, like liver failure, and others. Uh, there are always dips during the course of progressive deterioration here, in the prognosis. Chronic kidney disease prognostic factors. I kind of put a nice memo for it. SEC, poor functional status, poor nutritional status, advanced age, low serum albumin, okay, less than 3.5 gram per deciliter, is associated with 50% 1-year mortality. Modified Charlson comorbidity index, we'll be talking about it later, of more than 8 is associated with 50% year mortality. A presence of calciphylaxis is associated with 55% 1-year mortality. This is basically the modified Charlson comorbidity index. Remember, this index is so important because actually it can be used in any disease. The reason we use it for kidney disease because we don't have a lot of prognostic scores for renal diseases like other diseases like heart failure, for example. You have the New York Heart Association. For dementia, you have the FAST score and all that. That's why we use the Charlson Comorbidity Index in kidney failure. But in fact, it could be used in any disease. Okay? When you have a score of above 8, you have an annual rate of around 49 or 50%. So this is pretty serious. Uh, this is the Charlson Comorbidity Index. Each disease takes a score, like here, myocardial infarction takes 1, CHF takes 1, dementia takes 1, and so forth. Here, AIDS, metastatic solid tumor, and so forth. Who are the patients most likely to benefit from palliative and supportive care? Number one, patients with high mortality risk within the next year. Like, for example, patients who have chosen conservative kidney management with a GFR of less than 10 for the last 3 months, advanced age. Patient answer no to question, would you be surprised if the patient uh, died within the next 12 months? Functional decline, albumin less than 3.5, high comorbidity score, all these factors that we just talked about in the previous slide here. And then for patients also that consider withdrawal from dialysis or conservative kidney management. Also for patients with difficulty of end life decision making and determining goals of care and per patient request. Sometimes the patient will call, on the primary care and say, "Hey, I want to, talk to these guys from palliative care." All right, conservative kidney management, guidelines to manage complications of end-stage kidney disease and common symptoms have recently been developed. And the main focus is to maximize the quality of life. Uh, Renal dialysis, or what we call renal replacement therapy. We have indications for this renal dialysis. Metabolic acidosis, electrolyte imbalance such as hyperkalemia, intoxication from salicylates or magnesium or isoprostranol or lithium and so forth, fluid overload or uremic pericarditis. And this is the mnemonic, basically the AEIOU. All right. Now, withdrawal of dialysis. This is a very important question in the exam, by the way. If a patient is on dialysis, by the way, dialysis is a life support. So I cannot take the patient under hospice care unless the patient denies, dialysis. You see, but patient can stay in palliative care. All right. And in fact, actually, we see patients under palliative while they're taking their dialysis, but we cannot take them to hospice until they decline their dialysis. So in this situation, if they decide to stop dialysis, okay, you have to have a good discussion with the patient. Number one, you have to explain to them that uh, they have only like around 8 to 10 days left after discontinuation of the dialysis. So this is a serious problem. Number two, I would encourage them to get admitted to the inpatient hospice because of the high burden of symptoms they suffer from, like difficulty of breathing, pulmonary edema, all this kind of agitation, delirium. All these things can happen to them, and probably nobody will be able to handle them at home. So these are the hospice eligibility for end-stage kidney disease. Patients not seeking dialysis, creatinine clearance less than 10, serum creatinine above 8 with supporting documentation. As far as palliative care goes, we have so many symptoms to take care of, but these are the main symptoms that we get involved with. We'll start with the pain. I kind of gathered this from the literature. We have at least 10 causes of pain in kidney disease. I mean, kidney disease is not necessarily painful, all right? But, in these situations like renal osteodystrophy or dialysis-related amyloidosis, calciphylaxis, carnitine deficiency, cardiovascular disease like MI or a coronary artery disease, uremic peripheral neuropathy, procedure-related pain, autosomal dominant polycystic kidney disease is associated with pain, nephrolithiasis or kidney stones, renal cell carcinoma. These are the 10 causes of pain in a patient with kidney disease. So we'll start with the renal osteodystrophy. And basically, you can classify it to 3 categories: osteitis, fibrosa, osteomalacia, and adynamic bone disease. The osteitis fibrosa is related to increased bone turnover. Osteomalacia and adynamic bone disease are related to reduced bone turnover. And thus, we try to deal with this by treating the contributing factors of renal osteodystrophy. Like, for example, when you don't have vitamin D, you have reduced absorption of calcium, and then you have increased parathyroid hormone, and this will increase the phosphate, which will reduce the calcium. It's a vicious cycle. So you have to start giving medication that will reduce the phosphate. You start to give a vitamin B, and then you give a drug that mimics calcium, so you can reduce the parathyroid activity. Osteitis fibrosa ostica, and basically this is we'll call this brown tumor, and this is called the Rugger-Jersey syndrome. Basically, there's osteosclerosis at the edges of the vertebrae here. Again, osteofibrosis cystica, osteomalacia. You see all these, bending and fractures and all that. And the bone actually looks pretty soft because of the osteomalacia. Osteomalacia is the adult form of rickets, basically. And then you have the dynamic bone disease that's associated with bone areas here that's very tender, and then you have loose areas here. Again, this is something is only characteristic of chronic kidney disease. All right, and basically it's related to excessive suppression of parathyroid hormone by the use of vitamin D. So it's actually iatrogenic. Dialysis-related amyloidosis is a very important syndrome. It can be characterized by painful joints, carpal tunnel, spondyloarthropathy, and pathologic fractures. In the X-rays, you'll find like multiple bone cysts. We're going to show you this picture right now. So amyloidosis, the different types. The one that we're talking about is called the AH, which is dialysis-related. Okay, and you can pick it up with, checking out the beta-2 microglobulin here. This is the dialysis-related amyloidosis. These are the cysts that we see with it. Of course, you can do a biopsy and get a definitive diagnosis. chronic kidney bone disease, same things we just talked about. Now, we're going to jump to a very important topic, calciphylaxis, or what we call calcific uremic arteriopathy. This is something, guys, is extremely important in this disease. And if you find it, it has a high mortality rate. It's a very poor prognostic sign. And I'm going to give you a picture of it. So basically, it's an arteriopathy. Look at this. This is the skin. This is a huge ulcer here. And this is basically a section. And you can see the inflammation. The artery is basically, calcified. Renal cell carcinoma usually presents with hematuria and systemic manifestations. Sometimes it shows up as a classic triad of flank pain, hematuria, and palpable abdominal mass. Now, renal cell carcinoma can give you a lot of paraneoplastic, syndromes, like you see here, the parathyroid hormone-related peptide, erythropoietin, renin, gonadotropins, and so forth. These are the stages of renal cell carcinoma. Okay, we'll talk about how we deal with pain in kidney failure here. So we're gonna start like a WHO. We'll start with the anti-neuropathic medication, and on the top of these drugs is the gabapentin. Usually in end-stage kidney disease, I don't exceed 300 milligram of GABA or a 75 milligram of pregabalin. Now you can use tricyclics, but the side effects could be disastrous. I remember one time I had a patient in the ICU, and he had to send the plan because of the TCAs, and he had end-stage kidney disease. Of course, I asked them to stop it immediately. Acetaminophen is a good adjunct. I usually cut down the dose, even, in these situations, you have to be super careful because you don't want to accumulate the metabolites of acetaminophen. Now, as far as oral medications, the best short-acting medication you can give in these folks is hydromorphone, okay? Now, long acting, you can use fentanyl patches, you can use methadone, you can, use different medications. Codeine and tramadol is not the best choice here. Morphine in patients with less than 30 ml per hour is absolutely contraindicated in end-stage kidney disease because of the accumulation of M3G and M6G, which can give you significant, delirium because of these two metabolites. Again, hydromorphone is the best choice. Oxycodone also is not the greatest because of its metabolites and there's a potential of toxicity. Methadone can be used as a long-acting drug. In fact, I used to give methadone in kidney disease and it worked beautiful. But please, small doses. Don't overdo it. 5 milligram, maximum 5 BID. That's about it. Patches work well, and you can give, of course, IV if you want to, fentanyl or PRN. Alfenta is used, by the way, in Australia. Okay, for you guys that aware about Australia, they have different, medications. So they use Alfenta, which is basically 1/5 the potency of fentanyl, and it has basically the same properties like fentanyl. So I don't see a point that we use it, but they love Alfenta, methadone, fentanyl, Alfenta. Okay, again, this one is 1/5 the potency of fentanyl. All right, patches, buprenorphine. We don't have a lot of robust evidence up to now about buprenorphine and stage kidney disease, But generally speaking, you can use it because it's metabolized like fentanyl, somewhat. You can start, if you use these small patches for mild pain. The problem with the buprenorphine patches is the maximum is 20 mics. Okay, so you cannot go higher than this because of the prolongation of QT interval. But fentanyl patches, you can go up to 100, 200, whatever you want. So I would keep the buprenorphine for mild to moderate pain. Okay, periodontitis is a very common complication. And you see it in a lot of patients. They have atrophic and scaly and dry skin. Look at it. I saw this all the time, with these folks here. Uh, Now, you can use gabapentoids. You can use ultraviolet B phototherapy. You can use thalidomide. Thalidomide is a sedative that we used to use in last century here. Unfortunately, they used it in pregnant ladies to help with sleep and help with the morning sickness, but it turned that it is teratogenic and causes something called phocomyelin, and I'll show you a picture of it. So this is basically the algorithm here. Ultraviolet, phototherapy, gabapentoids, thalidomide, and then mirtazapine. I don't agree with this. I think mirtazapine should be before thalidomide because this is a more difficult to access drug here, thalidomide. So I would keep it as a last stage. But it works very well, by the way. All right. Of course, you want to make sure the patient is not pregnant. That's all. Now, ultraviolet rays, I've seen it. It works beautiful. But the main problem is you have to do a lot of sessions. Okay. So sometimes it's difficult for the patient to, commute back and forward to get this phototherapy. Gabapentin is good, maximum 300, or you can use pregabalin. Mirtazapine is a great antidepressant. You can use it also for chronic kidney associated periodontitis. Ultraviolet B, gabapentoids, again, the dose is 375 for pregabalin. They work on the N-type calcium channel blockers. Thalidomide, okay, um, use it at bedtime, will help quite a bit. This is what I've been talking about, the phocomelia, which happened, last century here in the 50s and the 60s. And it was a major catastrophe. Mirtazapine, of course, all of you guys know about it. It's called under the name of Remeron. Capsaicin can be used. By the way, capsaicin will come back later on. Capsaicin can be used in uremic neuropathy as well. You can put the patches and you can use higher concentration of capsaicin, like 0.075 percent. Okay, so capsaicin is used for both periodontitis and neuropathy in patients with chronic kidney disease. Another a good one is the doxepin. Doxepin is a TCA, similar to amitriptyline. Comes in a cream, 5%. The only big problem with it is sedation. Patient gets over sedated with it. That's all. But it's not a big deal. Actually, patients loved it. It was just expensive. That's all in the United States. So we had to, try to use cheaper methods before we get into it. Okay, tacrolimus ointment. This one is what we call calcineurin inhibitor, reducing the interleukin 2. Acupuncture, I've done this, as well. You can just put needles around the lesions here. Sometimes it does help, but again, you need a lot of sessions. We'll jump into anorexia cachexia. Chronic kidney disease is one of the causes of anorexia cachexia syndrome, such as CHF, cancer, COPD, CKD. inflammation, catecholamine. It's a complex metabolic pathway of interleukin 6, tumor necrosis factor, interleukin 1 beta, and interleukin 8, increase in the stress hormones. And this actually, causes things to be unbalanced here towards, lipolysis, proteolysis, and energy expenditure. Fatigue is a very common problem with renal patients, and this is related to anemia, related to depression, related to sleep disorders, and chronic inflammation. Also, other contributing factors are vitamin D deficiency, metabolic acidosis, and hyperparathyroidism. Anemia is a very important issue with chronic kidney disease, and this is basically shows you here in this picture, the pathophysiology of, you know, anemia in chronic kidney disease, and basically it's related to the EPO and the iron. And in fact, you can put them here. The reduced EPO or epitin, increased hepcidin. There's always true iron deficiency, suppression of erythropoiesis by inflammatory cytokines, and shortened erythrocyte, lifespan. And basically, this is a treatment here. We try to avoid blood transfusion, guys. Okay, for you guys in palliative setting, try not to use blood in end-stage renal disease. Use epoetin, use iron, use one of these HIF PhD inhibitors, and so forth. Okay, and this is again the consequences of anemia. It can lead to left ventricular hypertrophy. It can lead to congestive heart failure, exacerbation of angina, and other problems. Shortness of breath, again, these patients are volume overloaded, and so you try to give them high dose diuretics, and also they're anemic. So that's another reason they get short of breath. So in this situation, dialysis will be a good choice here. Opioids is good, as I told you. The main two drugs, short acting, are the hydromorphone and fentanyl. As far as benzos, midazolam is the best choice because it's short acting. Carnitine deficiency, we see it in chronic kidney disease and can lead to muscle weakness or myopathy, and can lead to muscle cramps. You'll see these guys urologists, the nephrologists give carnitine all the time. Uremic neuropathy. Okay, this is distinct from diabetic neuropathy. Okay, this is a sensory motor neuropathy here. All right, and you can use the usual drugs, gabapentinoids, and capsaicin and all that. But it's been shown that chronic dialysis may prevent neuropathy in some patients if it's begun early on. Also, renal transplantation is generally most successful method to prevent a neuropathy. These folks also they have autonomic dysfunction, orthostatic hypotension, and so forth. They can have encephalopathy and delirium. Okay, the delirium is characterized by EEG changes and slowing of generalized slowing and excess delta and theta waves. And in fact, they found that the level of azotemia correlates poorly with neurological dysfunction. You can deal with these by haloperidol or midazolam. So this is very simple, okay? Sleep disorders, is very common in these patients. The most important problem they encounter is the restless leg syndrome. All right, and the main drug we use is gabapentin. This restless leg syndrome, very common in patients with chronic kidney disease. Nausea and vomiting is also a very common problem. And you can see here, this is the effect of toxins on the chemoreceptor trigger zone. Okay? Chemoreceptor trigger zone is an area in the brain outside the blood-brain barrier. And this sends impulses to the vomiting center. And usually the treatment is 5-hydroxytryptamine antagonists like Zofran, like ondansetron, or D2 dopamine 2 inhibitors, like haloperidol, for example. All right? Depression is so common in these folks, and I recommend mirtazapine, guys, because it helps with the perivitis as well, or helps with sleep as well. So this would be my first choice in patients with end-stage kidney disease. Hiccups is a very common problem. Uh, it's a benign process, but still could be very irritating to the patient. Persistent hiccups is basically hiccups for more than 48 hours. And the management in chronic kidney disease, guys, I would say the first choice is gabapentin. Okay, if anybody asks you why, because the end-stage kidney disease, baclofen could cause toxicity, so you have to be careful with the dosing. I will never give more than 2.5 BID of baclofen in patients with end-stage kidney disease. The gabapentin dose, we talked about it, maximum 300. Metoclopramide, you have to cut down the dose. PPI would be a good choice if it's related to, GERD. All right, and then haloperidol is always there, but I would say it can cause, QT prolongation as well. So I would be careful, or I would start with gabapentin. I used to do phrenic nerve injections for these folks. So, but I don't, expect you guys to do that. I mean, it's simple, but it's you have to be an anesthesiologist to do this kind of shots. Now, non-pharmacologic techniques like sipping ice water, swallowing crushed ice, and all that is also good. This is just one method here. Drink ice water, hold breath, or breathe into a bag. So these are non-pharmacologic techniques for hiccups. Acupoints for hiccups, okay? Uh, you know, very easy to do on yourself. You can do acupressure. Use your thumb and push on these points. This is a suprasternal point here, and this one here between at the philtrum, and just push on it, and will help with your hiccups. Now, let's talk about the key learning points in end-stage kidney disease. Okay. First, palliative care is comprehensive, interdisciplinary care, focusing on pain and symptom management, advanced care planning and communication, psychosocial and spiritual support, and in end-stage kidney disease, the ethical issues in dialysis decision making. Remember, guys, dialysis is a life form of life support. So you can see a patient on dialysis as a palliative physician, but you cannot take him to hospice unless he's disconnected from the dialysis. All right. And this is a major decision, of course, because if you stop the dialysis or withdraw this patient from the dialysis, he's going to die within 8 to 10 days. This is a very common question. I've seen a lot of these guys in the hospice, inpatient hospice. The symptom burden, guys, is humongous. They get into delirium, they get into pulmonary edema, they get into dyspnea. I mean, you better admit them to the unit, inpatient unit. Don't ask them to go home. It will be a disaster. Okay? All right. End of life care is one aspect of uh, palliative care. And remember, palliative care encompasses end of life care, right? And incorporates all of the previous mentioned components, as well as hospice and bereavement care. End stage kidney patients and their families are appropriate candidates for palliative care because of their high symptom burden, shortened survival, and significant comorbidity. The usual pattern of illness trajectory is a progressive decline punctuated by episodes of acute deterioration. I showed you the picture early on, you know, organ failure in general, progressive deterioration, and then you get these dips, okay, of acute deterioration in between. Do you see? So this is very important. This is compared to cancer, guys. Cancer, there's a very slow progression there, and then all of a sudden you drop very quickly. Okay, I mean the thing that like in cancer, the family usually tells you, "Oh, he was doing very well. Like 1 week ago, he was working, doing this and that." And then all of a sudden he's not doing anything anymore. Okay, so there's a huge difference here, and different also from neurologic diseases, which it's kind of very flat from the get go and progressively go down. Palliative care has much to offer toward improving the quality of dialysis patient lives, as well as planning and improving the quality of their deaths. Palliative care plays an important role, in the quality of life for these patients. And you have to, as a palliative physician, introduce yourself to the nephrology team here. Okay, explain